Good evening. My name is Emil Shemich. I'm chair of the Department of Surgery at the University of Western Ontario in London, Ontario, and I'm a trauma and hip and knee reconstructive surgery. We're in the USA right now, and I'd like to welcome you to Insights, the World Tour, and I'll be moderating this session. This is a series of free, limited capacity online live events. We invite you to join leading academics and surgeons from around the world as we explore insightful and timely topics in a small group setting. Each session encourages interactive and engaging discussions, giving attendees the unique opportunity to collaborate with leaders and peers from across the world. So just some housekeeping notes. Just to remind everyone that this event is recorded. During the presentation period, you should be muted and have no video. In the discussion period, you can put your video on and unmute to ask questions. So how do you ask questions? Well, you can unmute, you can raise your hand on the Zoom app, or ask questions in the chat box to everyone, and we'll make sure that the question is communicated. Full recordings of this will be uploaded to the OE World Tour site after the World Tour event. So it's my privilege to introduce our guest speaker, Ron Silverman, who's the Chief Medical Officer for 3M Medical Solutions Division. He's a clinical associate professor of surgery at the University of Maryland School of Medicine. And his talk is entitled Negative Pressure Wound Therapy Evidence Review, the Promises Study. Ron?
All right, let's see, I'm gonna share my screen. Okay. Well, thank you, Dr. Shemitson. I appreciate this opportunity. I am the Chief Medical Officer for the 3M healthcare business, but I'm also a plastic and reconstructive surgeon at the University of Maryland Medical Center. Prior to joining industry full-time, I was Chief of Plastic Surgery at the University of Maryland, and about 11 years ago, or 12 years ago now, I joined as the Chief Medical Officer of KCI, the original, the company of the wound vac, as you most likely know. A couple years ago, 3M acquired KCI, and so now, and I stayed, and so I'm now working for 3M as their Chief Medical Officer, but I do still maintain a clinical practice part-time at the University of Maryland. And so today I'm going to focus on the use of negative pressure to be used over top of incisions, and I will focus on orthopedic aspects. But first, I thought I'd give a little bit of background about 3M. In case, for those of you who don't know, or many folks just associate 3M with consumer products like, for example, Post-it notes, Scotch tape. But 3M is a very large company all around the globe, over $32 billion in sales with 4 business groups, one of them being the healthcare business group, which I am representing today. There's nearly 100,000 employees, and they've been a Dow 30 company for a very long time, and the company itself is over 100 years old. Just a picture of where we touch pretty much everywhere. And if you walk into an operating room, it's hard to not be near. I think that the saying is, in general at 3M, you're never more than 3 meters away from a 3M product anywhere you go, but certainly that's true in the operating room. And here's just a few of the 3M products that I noticed when I heard that 3M had acquired KCI. I started taking some pictures in my OR. But 3M now, with the KCI acquisition, really is focused on allowing the surgeon to achieve the ideal surgical outcomes. And we have a lot of solutions, both pre-surgery, in surgery, and for the recovery after surgery. And this is just a little display of the various types of instruments we have. Some somewhat simple, some a little bit more complicated. And obviously, everyone is aware that 3M makes personal protective equipment, including, of course, the notorious, now famous N95 respirator. But one of the things that I've been really excited about is the incredible scientists and engineers that we have at 3M with tremendous expertise. And not only that, but 3M has tremendous manufacturing expertise as well. And so when you put this together with the knowledge and sort of leadership position that KCI had in wound care, it really sets us up to be a leader and innovator in that field, and we continue to do so. Historically, 3M and also KCI together have introduced really many new to world types of innovations, going all the way back to 1948 with the steri drape, and continue to innovate to this day. I'm not going to talk about all of these. I'm going to focus on one specific part of the portfolio, and that's Prevena. So most people, when they think of negative pressure for wounds, they think of VAC, which is really for open wounds. But knowing what we know about the science behind negative pressure and observing some surgeons and how they use the negative pressure and what we learned over the decades, we designed this product not for open wounds, but specifically to be used on closed incisions at the end of an operation, with the idea that you would use it in those patients where you're concerned that they have a risk or likelihood of getting a surgical site complication. And Prevena has demonstrated that, in high-risk patients, it can reduce these complications. How does that work? It's not simply just the suction away of drainage, although maybe that's what surgeons originally thought. And it does that. It removes drainage from the incision and takes it to a canister off at the pump site. But it does so much more than that. You can see from the image, it's the purple, what you see is foam, and it's made up of lots of little circles filled with air. And so when you hook this up to negative pressure, the air gets sucked out and you see the foam get narrow. You see it get flatter, but it also gets a little narrower. And when it gets narrower and it's taped to the skin, it's as if you're holding a hand on either side of the incision and holding it together, offloading that tension. And so it mechanically stabilizes and offloads the incision. We think that's a big part of what it does. But it also better approximates the skin edges together. And so because of that probably better approximation, we see a stronger incision. It's harder, in other words, it's harder to pull apart the incision, even if you remove the sutures, as early as day 2 or 3. And certainly it's harder while the foam is on. But if you remove the foam and try to tear it apart, again, it's stronger. It's harder. It takes greater force to pull it apart, even as early as 2 to 3 days, probably because of that better approximation. And we see that differential in the strength of the incision all the way up to 40 days when it starts to equalize. The scar is narrower. There's reduced edema. And that reduced edema is not necessarily from removing drainage through the incision, but rather from improved blood flow and therefore improved venous drainage and also improved lymphatic drainage. And we've measured both in clinical and animal studies reduced hematoma and seroma underneath the incision, even if there's no fluid suctioned out through the incision into the canister. And we believe that's from that better lymphatic drainage. And we've got really good, I'm not going to go through all the benchtop and animal studies, but we've got a lot of good evidence for that if there are questions about it at the end. Okay, let's see. It's not skipping. I thought I hid these slides, but I guess they're not hidden. But I'm going to quickly go through all these mechanism of actions. I guess I wanted to start here. So, as I mentioned, there's a lower amount of fluid underneath the skin. And so this is a study. It's a randomized controlled trial from Germany, a small study, 9 Prevena patients versus 10 controls. And these were patients that had total hip arthroplasties. And on day 10, they got an ultrasound, and you could see that the average volume of seroma in the control group was much higher, more than twice as much volume than the Prevena group. And as a matter of fact, there was some amount of seroma in 90% of the controls, but the majority of the Prevena patients had no seroma. So a similar study was repeated in hemiarthroplasties for femoral neck fractures and found very similar results. And these seromas were measured on day 5, again, by ultrasound. So these aren't clinically relevant complications or anything like that. This was a study specifically looking for fluid under the incision. And you can see in this study, in the fracture study, again, 80% of the control group had seromas. Only 36% of the Prevena had any fluid, and when they did, it was a very small amount. You can see the mean volume difference there. So, over the last several years, there have been a significant accumulation of clinical evidence. Many of these studies are totally independent. Some are sponsored by our company, investigator sponsored, and then we've got a large company-sponsored multi-center study that I'm going to go into a little bit more detail on. So right now, there's over 150 peer-reviewed publications on Prevena and over 24 randomized controlled trials. Here's 3 recent randomized controlled trials that I just wanted to show you because, when you pick the right type of incision to study, and that when I say right type, I mean when you pick a type of surgery that has a high enough surgical site complication rate, in general, you can demonstrate a very significant reduction in complications. And so what I'm showing you here is on the left is a randomized controlled trial on pancreatic cancer patients that had Whipple operations, pancreaticoduodectomies. All these patients have preoperative radiation, so that really puts them at high risk, plus they're cancer patients. You can see the controls have over a 30% surgical site infection, which is really high. And you can cut that down to less than 10% by using the Prevena device. A randomized controlled trial in Germany at 2 sites looked at surgical incisions of the groin for vascular surgery. A lot of these had Gore-Tex prosthetics placed, and it's a very similar type of reduction in infections. And then there's this randomized controlled trial from the Cleveland Clinic looking at revision knee and hip arthroplasties and showed a almost a little bit more than cutting in half the surgical site complication rate. And again, this isn't just surgical site infections, but it's complications. So it's in this study, it was infections, but it was also hematomas, seromas that required intervention, dehiscences, necrosis, drainage beyond 5 days. And you can see the difference is pretty significant. A meta-analysis, and this one was published in 2019, looking at all the studies specifically for Prevena. And I'll point out Dr. Jay Parvizi is one of the authors, who's a well-known orthopedic surgeon who focuses on infections. And this was a pretty significant meta-analysis. What you see in this forest plot are all of the non-randomized. So these are comparative studies that have control groups. These are non-randomized controlled trials. And you can see in this one, anything to the right of the line favors Prevena versus the controls. And it was a very, statistically significant P less than 0.00001 with an odds ratio of 3.15. So in other words, if you're in the control group, you have a 3.15 higher odds of getting a surgical site infection than if you're in the Prevena group. This next forest plot is just the randomized controlled trials. Now, this is a very heterogeneous group of studies because it's across different types of incisions, but what they have in common is that they're all high-risk types of surgical procedures. And again, you can see the forest plot to the right favor when you see CINPT, that means closed incision negative pressure therapy. And all these were using Prevena. And again, you can see it's about an odds ratio of 2.66, so pretty similar. Statistically significant benefit favoring Prevena over the control group in terms of the amount of surgical site infections. So we took all this evidence to the US FDA in 2019, and we requested a new updated indication because prior to this, we simply had an indication that said that, we apply negative pressure to the incision, it removes drainage when incisions continue to drain. And again, when incisions continue to drain. And again, that's not the main, in my belief, that's not the main reason why this benefits patients. It's one of them, but it's not the main one. So they actually accepted the evidence and they let us update the indication. So the new one is states that this Prevena system aids in reducing the incidence of seroma and aids in reducing the incidence of superficial surgical site infections. And to get that from the FDA is a pretty high bar. And so we were really pleased about that. And we're the only device on the market that has this indication. Okay, so let's focus on the evidence that is specific to orthopedic surgery. This is the earliest study publication specifically on Prevena in revision hip and knee arthroplasty. And what you can see here is, and this is Dr. John Cooper, he's an orthopedic surgeon right now at Columbia University. And what you can see is that this is 138 consecutive operations. He selectively used Prevena when he had very high risk patients. And that was his own judgment. This is an observational study reporting on his experience. But even though those Prevena patients were higher risk, you can see that the surgical site infections in the Prevena group were much lower than the rest of the patients. Only 1 out of 30 versus 18.5% of the rest of them that didn't have Prevena. And if you broaden that to include all wound complications beyond infections, the difference is even greater with 26.9% versus 6.7%. So we looked at that and we saw those rates. And so we did an economic analysis, and this one is in actually Canadian dollars. And we just said, knowing what the cost per surgical site infection is, and this $25,000 is based on publication on what's the average cost of getting a surgical site infection in arthroplasties. And you can see that had the control group used Prevena in all of the cases, it would have ended up saving over $3,000 per patient because of the avoidance of these infections. Dr. Cooper then did another similar study looking at periprosthetic fractures and found very dramatic reductions. You can see the lighter gray is the control group and the darker gray is the Prevena group, and a very significant reduction in wound complications, deep infections, and also reoperation in these complex periprosthetic fractures. And what you see in the picture, that's the customizable version, which is very long, it can be cut to size. It's up to 90 centimeters in length. So Carlos Higuera is an orthopedic surgeon at the Cleveland Clinic, and he saw these sort of historic studies, these retrospective studies, and he wanted to do a randomized controlled trial. So he submitted for an investigator-sponsored research grant from KCI at the time, and he looked at Prevena versus what was the standard of care at the Cleveland Clinic at the time, Aquacel AG, for revision hip and knee arthroplasties, and he looked at surgical site complications. The patients, in addition to being a revision, they had to have one or more risk factors, including this out of this list here. So these are the risk factors. They had to either be, obese, one of these things on the list. Most of them were obese or diabetic. And what he found was that the complication rate in the control group was about more than twice as high as in the Prevena group. It was statistically significant. And also the reoperation rate, which obviously has tremendous cost implications, was much higher in the control group versus the Prevena group. We saw this study and we went to Dr. Higuera and said, we ought to do this is fantastic. It's from the Cleveland Clinic. It's reputable. But if we really want to prove this, I think we're going to need to do a multi-center prospective randomized controlled trial. And so we asked Dr. Higuera, based on his experience with this, to be the PI. And we designed with him and with a panel of expert orthopedic surgeons a multi-center prospective randomized controlled trial, which has been published this year. And we call it the Promises Study. And in this study, we did a similar study to what Dr. Higuera did, but we limited it to knee revision arthroplasties because we knew that revision arthroplasties of the knee had a somewhat higher rate of complications compared to the hip based on Dr. Higuera's study. And so for consistency and to eliminate a variable, we decided to go with the knee revisions only. And very similar, this is the list. It had to be a revision. It could be septic or aseptic. And it had to have the patients had to have one additional high risk criteria as shown on this list. And just like in Dr. Higuera's study, most of the patients were on the list were included because they were obese, BMI greater than 35, or diabetic. But there were several others. Those were the two most common reasons. The study was planned to include 440 patients based on our predictions. However, we did an interim analysis after enrolling half the patients, and the difference was so great. And we set up a criteria before the study that if the difference at the interim reached a threshold of a p-value less than 0.005, then we would halt the study. And so we did halt the study because at that point, the authors felt, and our safety group felt, that it was no longer ethical to randomize patients to the control group when we knew that there was such essentially the control group had a fourfold higher rate of complications. So we stopped the study at that point. We ended up, during the analysis, enrolling a little bit more patients. So we ended up with close to 300 patients. 294 patients were enrolled. So here are the results of the study. Again, 15 centers. And what we found was that at the 90, well, first of all, if you look to the right, you can see that the rate of complications, again, was about 400% higher in the control group compared to the Prevena group, which is in red. And that was pretty consistent at 30, 45, and 90 days. If you look here, you can see that the 90-day readmission rate to the hospital was about 3 times as high in the control group, 10% versus 3.4%, statistically significant. And if a patient was readmitted and they were in the Prevena group, their length of stay for the readmission was much shorter, 8.6 days compared to 2.2. And there were very few patients that were admitted in the Prevena group. But I guess what that implies is that if you had Prevena and you had a problem, it tended to be a lesser problem. The magnitude of the wound complication or what have you seemed to be less if you had Prevena. Some other evidence. This is a study that looked at, formatting's a little bit off here, but this is primaries. So the question is, well, okay, revision's fine. We proved a very great difference in revisions, in high-risk revisions, so people that had a comorbidity plus were getting a revision. But what about primaries? So this is a study out of Toledo, Ohio, about 600 patients, 400 controls, a little less than 200 in the Prevena group. It's retrospective, so this was just a single surgeon's experience in Toledo, Ohio. But he found that his surgical site infection rate and his surgical site complication rate and hematoma rate, et cetera, was reduced statistically significantly with Prevena, even though the patients were primaries. So, the question is, 3.5% infection rate in a primary arthroplasty is high compared to the literature. And so we looked into it, we talked to him. He's in Toledo, Ohio. And so for those of you from Canada that don't know Toledo, in Toledo, people, when you order a salad, they come with French fried potatoes on the salad. So basically, it was not a low risk group, and the average BMI was high, and so it was essentially an obese population. And so you might not, although these were primaries, I would still say that they were higher risk. One of the things that was interesting is that their pain was noted to be less during the 24 hours postoperatively, as reported in the chart. Their length of stay was less, their swelling and edema was less. This is probably a better study for the use of Prevena in primary arthroplasties. And this is out of Columbia University. It's Dr. Cooper. But that's because they went back and looked at their historical experience at Columbia, and they created a scale where they can rate the risk of someone getting a surgical site complication if they're getting a primary arthroplasty. And so essentially you get a point for being too thin, you get a point for being obese, 2 points for being greater than 35 BMI, 3 points, etc. And if you have 2 points or greater, then they basically did their risk assessment. They said you ought to get a Prevena. And so then they implemented that policy at their hospital. And what they found was that the historical control group, okay, in the low risk patients had an 8.6% wound complication rate, but the high risk patients that had 2 points or more had 26% complications. These are primary arthroplasties. And so when they started their Prevena study, they found that you can get those high risk patients down to 7.3%. So similar complication rate to the historic. In other words, you can lower the risk of your patient from a high risk patient to a low risk patient by using Prevena. Interesting study. And it's a very simple risk factor table, which I like about it. And this is another study from Georgetown looking at primary arthroplasties. And what he did was he looked at, his outcome in this study was whether or not they had to have a reoperation for a complication. And you can see that it was statistically significantly much lower in the Prevena group. He was using Prevena in his high-risk patients selectively, and so this is a retrospective. So this has the additional component, similar to some of the other retrospective studies, that there's a selection bias towards in other words, the Prevena patients happen to be generally higher risk because the surgeons are choosing those patients to get Prevena. And that's the evidence that I'm going to show for arthroplasty, but I'll also just say that there's a little bit of growing evidence on use of Prevena in open spine surgery. And here's a study out of Georgetown University, a nice size study, as you can see, and 156 control versus 118 Prevena, and a very significant reduction in surgical site infections. And a second study out of Ohio State University, also showing a very significant reduction. This is a smaller study, but zero. We'll take zero. That's good. 0 infections in the Prevena group. Usually, by the way, it's not 0. I mean, that you can't prevent all infections, but this one happened to be. Okay. And this is actually a vascular surgery study, but it's in amputations, and it's an area that's of growing interest to us because we do know that when a patient that has had an amputation gets a wound complication, it delays their ambulation, it delays them getting a prosthetic, and it can contribute to the overall morbidity and maybe even mortality in that very difficult group. And this showed a very significant reduction in wound complications in the Prevena group getting amputations. So I'm just going to briefly show a couple of cases of mine. Again, I'm a plastic surgeon. This is a lot of soft tissue. There are bones underneath all this soft tissue, quite far away from the surface, but this is a patient that actually had a hernia and it was in a lot of pain, and the general surgeon asked me if I could work with him and do a paniculectomy, removing the excess tissue, because he was worried that it would just be a setup. She would automatically have complications. Normally, a paniculectomy in a patient like this would be a guaranteed some kind of wound complication somewhere. But I use Prevena, and this is the customizable version, which you can cut and sort of arrange for nonlinear. I do an inverted T type of incision. And you can see here before and after, not one spot of wound breakdown. I was very pleased with this, and it's very unusual. This is a patient of mine that had, she came to me after she was rejected by 2 other plastic surgeons in the Washington, D.C. area. And I'm in Baltimore, which is nearby. But she basically had tumors removed from her breasts. She had breast reconstruction with implants, and she had a wound healing problem. The implant extruded. She had ischemia to the nipple area on one side. And so and you can see she's very skinny and has almost no subcutaneous fat. You can literally see the veins in her ribs through the skin. But I said to her, look, if you're willing to take the risk, I believe I can get you a good result if you allow me to use this device, Prevena. And so I did. I implanted silicone breast implants, and you can see the Prevena devices there. And she ended up with a really nice result, not one tiny wound complication. So very pleased with that. This is an interesting case where a surgeon, it wasn't me, but the surgeon had a Prevena that was too small. So he placed it and asked the rep to get him a longer Prevena. And so what you have here is the very unusual opportunity to take a picture of the incision after Prevena was only on for 4 hours. And you can see the demarcation line right about here. To the right, you can see that bruising and swelling around the incision where there was no Prevena, but where there was a Prevena, look at the difference. It just looks like a different incision. Quite remarkable. So she ended up getting the longer Prevena placed and then, healed quite well. Similarly, this is a obese woman that had, these are two pictures of two different women that participated in a study at Duke University for obese women getting C-sections. And one of the things that this study showed, and by the way, this on the left is a patient that had a C-section, and this is at day 7, and she did not have Prevena. She had the controlled dressing, and you can see like that bruising below the incision. You can see that swelling. There's no complication here. There's no wound breakdown, but it's just edematous. It has that peau d'orange appearance. And this is also, the one on the right is also 7 days, but it looks like a 3 or 4 week old incision, and the surrounding tissue is soft and supple, and there's no edema. And all of these patients, they were all obese, and this is what you see. Anyone who's used Prevena can tell you that it's amazing the way the incisions look and the way the surrounding soft tissue looks when you remove it. And one of the notable findings was that, and I mentioned this was the case in that primary arthroplasty out of Toledo study, but they noted less pain, statistically significantly reduced patient-reported pain, both at rest and on palpation. And this pain was less, not only during the first week, but also even at 6 weeks. Very interesting. The women said that they felt like the Prevena was like supporting their abdomen, almost like holding them together. And they didn't want to have it removed because it felt unsupported when they had it removed. So we went back and we looked in this study, and there was actually a statistically significant reduction in the amount of opioid use during the hospital stay in the Prevena patients. A pretty significant, I want to say like, it was like a third less, and it was statistically significant. So this is a patient from that had a hip fracture, and she had surgery for that, hemiarthroplasty. This is after 6 days, and the Prevena has been removed, and you can see the outline of where the Prevena was, and it's very easy to notice that where the Prevena purple foam was, there's no bruising, or very little bruising, and just beyond, there's a lot of bruising. So we think that's from that improved, blood flow and lymphatic clearance that you get underneath the foam. And so we went ahead and we designed versions of Prevena. We call them Prevena Restore, because we're basically seeing that Prevena is more than just about reducing complication. It enhances the healing. It seems to accelerate the healing and reduces not necessary complications, but just swelling, edema, and makes for a faster overall recovery. And so we've designed Prevena Restore it does manage the incision and the peri-incision, but it's also intended to manage the surrounding soft tissue. And so we have various shapes. These are some artwork of those shapes. And here's some of the shapes on patients. And you can see on the left, this one was designed specifically to be placed around the knee or around a joint. This middle one is ideal for breast reconstruction. This one on the right works very well around the ankle. This is actually an ankle fracture patient. And you can see the one for we call it Prevena Restore Arthroform. The one for the joint is intended to allow movement and motion. And sometimes surgeons use these in creative ways. And these are the ones that I showed you, that various shapes are being placed on an abdomen, on a hip. This is on a plastic surgeon placing it on buttocks after fat grafting to improve blood flow. So, you know, once surgeons see the benefit of this, we learn a lot from the way that these devices are used. So I'm going to stop there and open it up for questions. Thank you very much for your attention.